Ladies and gentlemen, with these beautiful scenes from Serbia, we wish you a warm welcome to Belgrade for the second Balkan Rhino-Forum. The second Balkan Rhino-Forum is a scientific gathering of rhinologists from the Balkans with the aim and purpose of improving rhinological science and creating a regional scientific network. The forum was established 2 years ago in Skopje, Republic of North Macedonia. We are very pleased that this year Serbia is your host. We have the honor to host lecturers and participants from 22 countries, and we can say that this scientific network is spreading beyond the Balkans. The organizer of the second Balkan Rhino-Forum is Rhinology and Allergy Association of ENT section of the Serbian Medical Society and is held under the patronage of the European Rhinology Society. The technical organizer is medapp Association from Belgrade. We hope that apart from the new knowledge from rhinology, you will also take away nice memories from Belgrade and Serbia. And of course, the date of this event is special because Belgrade is the most beautiful in April. As the famous poet Mika Antić once said, "So come the days when you do not recognize the colors of April. You do not recognize your hands, you think they are wings." The friendly staff of the splendid Hotel Metropole Palace and hosts from the medapp Association will make you feel comfortable during the symposium. Now I invite Assistant Professor Dr. Aleksandar Perić, President of Rhinology and Allergy Association of ENT section of the Serbian Medical Society, to have a word and to greet you.
Thank you, Marina. Ladies and gentlemen, dear colleagues, welcome to the second Balkan Rhino-Forum, Sinusitis, Scull Base, and Rhinoplasty Symposium, with 4th Symposium of Rhinology and Allergy Association of Serbia. This year, the main organizer of this international symposium is Rhinology and Allergy Association of Serbia as a part of ENT section of the Serbian Medical Society. It's my pleasure to announce that for the first time in Serbia, organizer of is also European Rhinological Society, which is also our Congress is under the auspices of European Rhinological Society. And our technical organizer is medapp Society, the best organizer of medical events in Serbia. Rhinology and Allergy Association of Serbia is founded in 2015 as a part of ENT section of the Serbian Medical Society. And the mission of the Rhinology and Allergy Association of Serbia is to serve, represent, and advance the science and clinical practice in the field of rhinology, to promote excellence in patients' care, research, and education in the fields of inflammatory nose and paranasal sinuses diseases, as well as in the fields of functional, reconstructive, and aesthetic surgery of the nose and endoscopic sinus surgery, and to provide communication and fellowship to the members of rhinological community. The aims of our organizing committee are to make the symposium open to all parts of the world, not only to participants from Balkan countries, and to keep the interest of young colleagues, residents, and young academicians in mind when designing the program, especially in the parts of our program with ERS junior members. Our scientific program consists of plenary sessions with invited speakers, e-poster sessions, and ERS junior member session. It's my pleasure to announce for the first time in Serbia ERS junior session, how I do it, with chairperson, my dear friend, Dr. Aleksandra Barać from Belgrade, from Clinical Center of Serbia, the best young scientist in the fields of medicine in Serbia, and with moderators, Dr. Paul Surda from London, from United Kingdom, President of ERS Junior Member Board, and Dr. Puya Degani Mobaraki from Perugia, Italy, founder and president of Naso Sano, a non-profit association that provided award of the best junior abstract. First Balkan Rhino-Forum was organized in 2017 in Skopje, in North Macedonia, under the auspices of European Rhinological Society, very successfully by my dear friend, Professor Gabriela Kopacheva-Barsova from Skopje, and with very good cooperations of Professor Christos Georgalas and Yanis Konstantinidis from Greece, Professor Mark Scheithauer from Germany, Professor Cem Major from Turkey, and Professor Peter Valentin Tomažić from Graz from Austria. And those are the pictures of this first Balkan Rhino-Forum. I'd like to thank Gabriela Kopacheva-Barsova for organizing this very, very successful international symposium. This year, it's my pleasure to announce the participation of more than 200 people from 22 countries, invited speakers, e-poster speakers, and other participants from Albania, Austria, Bosnia and Herzegovina, Bulgaria, Croatia, Egypt, Finland, Germany, Greece, Italy, Latvia, Montenegro, North Macedonia, Palestine, Portugal, Romania, Russia, Serbia, Slovenia, the Netherlands, United Kingdom, and from the United States of America. It will be impossible to organize this big scientific congress without the financial support of our dear friends from the pharmaceutical companies. And this year, our golden sponsors are Galenica and Hemopharm. Our silver sponsors are Essenza, Life Medic, Emifarm, Octal Pharma, Ceomed, Mylan, and Alpen Pharma Group. Our bronze sponsor is Amicus, and other sponsors are Alvogen, LRM, Sibexline, Unifarmedicom, and Bionorica. It's very important to present BRF International Scientific Committee. Professor Witge Fokkens from University Clinical Center in Amsterdam in Netherlands, Secretary General of the European Rhinology Society, Editor-in-Chief of Journal Rhinology, and Associate Editor of Journal Allergy. Professor Sarah Weiss from Emory University in Atlanta in United States, first author of International Consensus Statement on Allergy and Rhinology with the main topic allergic rhinitis and other forms of chronic rhinitis. Professor Nicholas Busaba from Harvard Medical School, from Massachusetts, Boston, from the United States, very important researcher in the field of chronic rhinosinusitis, and especially in the different treatment modalities of chronic rhinosinusitis with and without nasal polyps. Professor John Del Gaudio from Emory University from Atlanta, USA, past president of the American Rhinologic Society. Professor Sergei Karpischenko from St. Petersburg State Medical University from Russia, and the organizer of the Rhinology World Congress in St. Petersburg in 2021. Professor Yanis Konstantinidis from Greece, from Thessaloniki, professor in the Aristotle University in Greece, and the organizer of European Rhinologic Society Congress in Thessaloniki next year. Professor Christos Georgalas from Athens, from Greece, very important surgeon in the field of endoscopic sinus surgery and skull-based surgery. My dear friend, Gabriela Kopacheva-Barsova from University Clinical Campus St. Mother Teresa of Skopje, North Macedonia. Professor Mark Scheithauer from Ulm, Germany, very important surgeon in the field of aesthetic and functional surgery of the nose. Professor Rajko Jović, president of ENT section of the Serbian Medical Society. My dear friend, Professor Livije Kalođera from University Hospital Sestre Milosrdnice from Zagreb, from Croatia, very important researcher in the field of rhinology and allergy, not only in Croatia and Europe, but also in the world. My dear friend, Professor Tomislav Boduen from the same hospital, Zagreb, Croatia, president of Croatian Rhinologic Society. And it's very important to note from 2010 to 2018, Professor Boduen organized 5 very, very successful, excellent congresses in the field of rhinology. And the communication of Rhinology and Allergy Association of Serbia is just the best with the Croatian Rhinological Society. And my friend, Professor Diljana Vičeva from Medical University of Plovdiv in Bulgaria. I'm Aleksandar Perić from the Military Medical Academy and president of Rhinology and Allergy Association of Serbia. My dear friend, Ljiljana Jovančević from Clinical Center of Vojvodina, ENT Clinic, and she's secretary of the Rhinology and Allergy Association of Serbia, secretary of ENT section of the Serbian Medical Society, and Serbian representative and in advisory board of the European Rhinology Society. And my dear friend, Dr. Aleksandra Barać from Clinical Center of Serbia, Vice President of ERS Junior Member Board. Our invited speakers are really excellent this year. Professor Nikolas Busaba, Yanis Konstantinidis, John Del Gaudio, Vicke Fokens, Christos Gergalas, Rajko Jović, Sergej Karpiščenko, Gabriela Kopačeva-Barsova, Mark Scheidhauer, and Sarah Weiss. And those are the executive invited speakers. Our international speakers in alphabetical order are Aleksandra Aleksić from Clinical Center of Banja Luka, Bosnia and Herzegovina, Aleksandra Barać, Clinical Center of Serbia, Tomislav Boduen from Zagreb, Croatia, Maja Bulčić-Čupić from Novi Sad, Serbia, Francesco Busu from Sassari, Italy, Ljiljana Čvorović from Clinical Center of Serbia, Puja Degani Mobaraki from Perugia, Italy, Jetmira Feza Bulaj from Tirana, Albania, Boris Jelavić from Mostar, Bosnia and Herzegovina, Ljiljana Jovančević from Novi Sad, Serbia, Livije Kalođera from Zagreb, Croatia, Vladimir Kljajić from Novi Sad, Serbia, Milica Labus from Belgrade, Serbia, Bošćan Lališnik from Slovenia, from Maribor, Milanko Milović from Belgrade, Serbia, Katerina Mitrović from Podgorica, Montenegro, Jane Netkovski from North Macedonia, from Skopje, Ivana Pajić-Matić from Slavonski Brod, Croatia, it's me, Aleksandar Perić from Belgrade, Serbia, Snežana Sanković-Babić from Belgrade, Serbia, Slobodan Savović, Novi Sad, Serbia, Roven Sinani, Tirana, Albanija, Tanja Soklić-Košak, Slovenija, Ljubljana, Milan Stanković from Niš, Serbia, Paul Surda from London, United Kingdom, Timoleon Terzis from Athens, Greece, Aleksandar Trivić from Clinical Center of Serbia, and Professor Diljana Vičeva from Plovdiv, from Bulgaria. Finally, I'd like to present our BRF organizing committee. My dear friend Ljiljana Jovančević, I'd like to thank Ljiljana for her kind support during the preparation of our scientific program. Professor Rajko Jović from Clinical Center of Vojvodina, I'd like to thank Professor Rajko Jović for her kind support from the first time after we organized the Rhinology and Allergy Association of Serbia in 2015. Aleksandra Barać from Clinical Center of Serbia for her kind support in communication with ERS Junior Member Board. My dear friend Dr. Jelena Sotirović from my clinic, due to the very good communication with invited speakers. Uglješa Grgurević from my clinic and president of Medapp Society, the best organizer of medical events in Serbia, and Bojana Petaković from Medapp Society. I wish all very good stay in Belgrade during the BRF Belgrade, and I'd like to call Professor Vicke Fokens, Secretary General of the European Rhinology Society, to greet this symposium. Thank you very much.
Thank you very much, Alexander. It's a real pleasure to be here as invited speaker, but also a little bit on behalf of the European Rhinologic Society. And Alexander was so kind to give me the opportunity to advertise a little bit for the European Rhinologic Society. I think it's very, very important that so many people from the Balkan area are together here, because you are the future of Europe, and you have to be a very important scientific new part of Europe, and you have some very smart young people sitting here in the audience who will make that happen. And I really hope that the European Rhinologic Society can support you to do that. What is the society doing? Well, as you notice, we inform you with newsletters and website, and the junior members are very active on Facebook. I left that when my kids kicked me out 20 years, defriended me 20 years ago, but I know what it is. We have Twitter and Instagram. Every year we award 5 fellowships for people usually in countries that cannot so easily afford it, to attend a course somewhere in Europe, and you can find the course you want to go to and apply for that. Every 2 years we have 20 to 40 travel grants to visit the ERS Congress for junior members, and every 2 years we have 2 research prizes for the best clinical and the best basic paper. It is difficult to get the best papers for people to really send them in, so if you're here and you think you have a good paper, send it in, then we can award you a prize. If you don't send it in, that's very difficult. We try to lobby at the EU level for better care for our patients. For example, now we're very active in trying to get monoclonal antibodies like anti-IL-4 and IL-5 admitted into Europe also for nasal polyps, not only for severe asthma. We publish 2 journals. Rhinology and Rhinology Online. I just said to Sergei that being an editor-in-chief of Rhinology is not always fun. We have an acceptance rate of 13%, and that is a very frustrating business because 87% of the authors who send the paper come later and say, I'm so sorry, I sent my best work to you and you didn't take it. So to make that a little bit easier, we decided this year to move to 6 issues a year instead of 4. And hopefully that will give a little bit space, but what gives much more space is the start of the new journal, Rhinology Online. It's open access, and we have 2 goals. And one goal is to help authors to make their paper better. So we really spend a lot of time on reviewing and increasing quality of papers, and all that within 2 weeks. So we really promise if you send your paper in, you have it back in a week. If you send it in again for revision, you have it back in a week again. It's a lot of work, but I think it's worth it. Then we organize and fund positions papers. You find them in Rhinology as supplements, olfactory one from last year, the new EPOS next year, and of course we have our biennial congress. For all this work, it's very important to have members, not only members that pay a little bit, it's very cheap to be a member, but also members that work for ERS. So I would like to ask you all, please become member of the ERS and become an active member and help us to fulfill and do all the things we can do. Here in Serbia, Professor Ljiljana Jovančević is the delegate, so she can give you more information, but if you want to know something, you can always ask me too. And finally, of course, next year we will have the new ERS Congress in Greece, in Thessaloniki, and I hope that I see all 200 people now in this audience there again. Thank you very much.
Thank you, Professor Vidge-Fokins. I'd like to call Professor Rajko Jović from Clinical Center of Vojvodina, President of ENT section of the Serbian Medical Society.
Thank you, Alexander. Dear colleagues, ladies and gentlemen, you believe me that this Rhino-Forum, this meeting is a great event for our Serbian Rhinological Society. As the president of the Serbian ENT Society, I would like to inform you that we have 560 members and that we are organized so that we have 7 small associations, and one of them is this Rhinological Association. They are a small group, but as you see, they are very active. They are youngest in our association, and I really want to say thank you, Alexander, because you had the courage to organize such a nice meeting in Belgrade, in Serbia. I think the last 20 years, that is the second international meeting in our country. Thank you for that, exactly to you. I know that there is very distinguished guests, and thank you for your coming. Your coming, your arrival, improved me that you really respect our Rhinological Association. This meeting is the way how we will, I'm sure, rise our everyday work, but also I'm sure that we will rise the respect of our Rhinological Association in the international association. Well, now I know that there is somebody from the European board, and I like to take the nice impression and to transfer that to the board and to give a chance to this group to organize something on high level. European Congress, for example, Rhinological Congress, that's my wish. Well, really enjoyed in this meeting, not only in the lecture, which you will be able to hear, but also in the whole events, because I'm sure that Assistant Professor Alexander Peric gave his best to present you his hospitality and his warm heart. Thank you and enjoy this meeting.
Thank you, Professor Jovic, from really great message. And I'd like to call very important person, Professor Ljiljana Jovančević from Clinical Center of Vojvodina, Serbian representative in the European Rhinological Society Advisory Board and Secretary of Rhinology and Allergy Association of Serbia.
Poštovane koleginice I kolege, dear ladies and gentlemen, dear colleagues, dear friends. Welcome to Serbia once again, welcome to Belgrade. Thank you all for coming. When we talked about this event 2 years ago, it didn't sound like it will be possible to see you all here. And now, as you can see my face, I'm really happy because I really am. Thank you, thank you, thank you for helping us organizing this wonderful meeting and making it scientifically so strong. Since I am the representative of Serbia in the ERS, I allow myself to present a few slides. But before that, I forgot to thank Alexander because, yes, I've been helpful, but most of the work was done by him. So thank you, Alexander, for bringing us all together, and we wish us all a successful meeting. So about European Rhinologic Society, as you know, was founded in 1963. Please help me, Professor Fawkins, about the pronunciation. Van Dishoek. So you see the previous congresses that took place from 1984 in Nancy to 2018 in London, England, organized and being president by Sean Carey. Now Secretary General of the ERS is Professor Fawkins, and we are really honored to have her here. Thank you so much for supporting us. And the president of the European Rhinologic Society is now Professor Sean Carey from United Kingdom. Now I wanted you to see him also. Then we have the Juniors Society. Professor Pavel Surda is here. I don't think that he's here in the room, but he's one of the faculty members, so you will be able to meet him. He's the president of the Junior Society, and something that we are so proud of, that is Professor Aleksandra Barać, who used to be the president of Juniors, and she's very helpful, as Professor Fawkins knows, in the ERS. And thank you so much, Alexandra, for being for being our friend, our colleague, and thank you for so that we can be so proud of you. Now there's one interesting thing that appeared, I think, this year, that you as an ERS member can also become a member of the American Rhinologic Society for a reduced price, that is $50, just a membership, or $80 including subscription to the International Forum of Allergy and Rhinology. You've heard about rhinology. Now it's the 56th year that Rhinology Journal is being published. It's an official journal of the ERS and the International Rhinologic Society, and its impact factor is 2.9, which is absolutely unbelievable for an ENT journal, so that you know that it's really something. It's M21. It is being published 6 times a year. The last Congress took place in London in 2018. We had more than 1,800 delegates from 86 countries. It was a wonderful meeting. The next one, as you've heard, will be in Thessaloniki, so I will also like to invite you to Thessaloniki. And after 2020, we will have a meeting in 2022 in Bulgaria, in Sofia. So you're also invited to join us in Bulgaria in 2022. Now something we have to say that a very sad thing happened last year, something that none of us expected, which is that Professor Heinz Stamberger passed away. It happened in December last year, as you know. And I think there are absolutely no way to say how to pay tribute to Professor Heinz Stamberger. I think it's really impossible. So I decided to read a few lines to you from obituary written by Professor Valerie Land. She's the first lady of rhinology, so she wrote very nice words, and I would like to share these words once again with you. It seems almost unbelievable to be writing about the loss of Heinz, who passed away completely unexpectedly on the 9th of December 2018. Heinz was influenced so many careers that, like many of you reading this, it is hard to express how shocked I am by this sudden loss. To say that he had a major impact on ENT and specifically on rhinology would be a huge understatement. Without his supreme surgical skill, endless enthusiasm, and superlative linguistic skills, chronic rhinosinusitis would have likely remained an unattractive clinical backwater, and endoscopic sinus surgery would not have taken the world by storm. He was an indefatigable teacher, running hundreds of dissection courses and lecturing throughout the world from the early 80s right up to the last weeks. He was president of innumerable international congresses and societies, was a founder of the Society of Minimally Invasive Therapy, and his fast courses run in German and English each year in his department in Graz, Austria, were the go-to destinations for endoscopic endonasal techniques. He published widely, and his first textbook, Functional Endoscopic Sinus Surgery, in 1991, was the Bible for this technique. He was personally responsible for the introduction of extended endoscopic style-based surgery and many of the innovations that accompanied from fusion imaging to instrumentation and packing. Heinz was a true pioneer who was continually looking for new ways to enhance our knowledge and disease management. But as you all know, Heinz was much more than an inspirational doctor, surgeon, and rhinologist. He was a true Renaissance man, interested in everything from prehistoric rock art and archaeology to all aspects of the natural world, from geology to gastronomy, from philosophy to photography, from diving to deserts. He traveled to every continent, often with his lovely wife Dolores, who shared his many interests. He was the perfect companion in so many meetings in far-flung parts of the world, displaying a wonderful, subtle sense of humor when things did not always go according to plan. He was simply one of the most interesting people I have known and who I have been deeply privileged to call my friend. So I was thinking how to pay tribute. I mean, every time each and every one of us takes the endoscope into your hands, we are actually paying tribute to Heinz Schamberger. So and I can just say goodbye, dear teacher, and goodbye, dear friend. We will all miss you very much. Thank you.
Serbia is a country with rich culture and tradition that we are extremely proud of. Serbia is also a country of beautiful nature and excellent food and wine. We receive you, our dear guests, in our hearts, and we are proud of our hospitality. The most beautiful way to present a country is to combine the beauty of youth and tradition. Such a combination is best represented through folklore, our traditional play, and folk costumes. Through the compilation of Serbia's plays, the folklore ensemble Thalia from Belgrade will now perform for us. Please welcome them. Thalia. Well, this was quite interesting and amazing. Thank you so much, Talia. Thank you for the wonderful performance. Do you know that here in Serbia, people actually grow a lot of various fruits, and we have a secret formula how to transform it into a traditional drink called rakia, and which stands alongside the listener's heart. Now you will have the opportunity to taste a part of it. And once again, welcome to Belgrade, and now we are inviting you for a welcoming drink. But before that, I also invite our dear lecturers to step forward in order to make a few photos as a great memory. Thank you so much. Have a nice day. Please, all the lecturers can now step forward. We will make mutual photos. In front. So please, now it's time for you, when you take rakia and hearts, to go out and make a few photos. Thank you once again.
Ne znam, čuli su.
Now, once again, you are all invited for a welcome drink. We are waiting for you at the front hall. Thank you.
spring, the report, and then is this, the steps, the closure.
We're going to talk about the instruments you use.
The instruments
also.
and the investigation, and then this, the investigation.
That's interesting.
And the same, the tiny thingy. And that's how it looked like. It's a small one, the closure.
You use endoscope or what?
Yes.
And
And this, wait,
leakage.
yes.
What is this? Is this liquor?
Liquor coming from the nose, yes.
Oh my God, it's difficult to detect that, as far as I understand.
Actually, this I will take away because there's
Sometimes
not
you
enough
don't
time.
know.
Good. Skip slide.
Okay.
1, 2, 3, 5, 7, 7, 5, 5, 7, test 1, test 2, test 1, 2, test 1, 2.
I don't know where it's that. Sella is Sella.
Test 1, 2, 1, 2, 5, 7, 7, 5.
What is ICP?
Okay.
Okay. Ladies and gentlemen, oh, you're going to start first? Good.
The first session of the BRF Belgrade is Advanced in Rhinology. I'd like to call Professor Witzke Fokens as the first speaker.
Well, again, thank you very much for inviting me. And I must say, this was a terrible assignment. Future of Rhinology in 15 minutes. I put 20 minutes, and then I got back 15 minutes. So I didn't change it, but I will try 15 minutes. We can skip that. That's 1 minute less. So when I think about the future of rhinology, what will be there when I'm 80 years old and you're all grown-ups and the young people here in the audience, what will be different? And what are we trying to do in the next years to change? What are the things we're talking about together when we have a drink together? And I try to group it in 3 themes and 5 things I think are relevant in the coming years. And I think we should have much more attention to prevention of disease. And prevention is not only primary prevention, saying that a patient doesn't get the disease at all, but also secondary prevention, that it's not becoming worse over time. There is a lot going on in diagnosis at the moment, and it's still at the level of we know a lot more, but we're not yet able to use it in our daily practice. So look a little bit at that. And of course, we always want better treatment for our patients. And if we look at the things that really, I think, are going to change in the next 5 to 10 years, or is already happening, it's definitely big data. It really helped us to understand things, and I will give you a few examples. Patient participation is the whole digitalization of our world makes patient participation much easier. I will show you some examples. We understand a lot more about pathophysiology. We have real-life data and get more and more understanding how different real-life data can be from the randomized controlled trial that we all felt was the golden grail of our normal work. But now we see papers coming that actually only 5% of our patients can be included in a trial. And then people saying, yeah, but if only 5% of the patients can be included in a randomized controlled trial, how relevant is that trial for my daily practice? Maybe real-life data can fill that gap, and then all the new possibilities of analysis will help. If we speak about rhinology, of course we think of rhinitis, rhinosinusitis, nasal polyps, but of course also sleep medicine, olfaction, skull base, facial plastic, many things. But most of my talk will be about the center of this cartoon. And of course it's not only the upper airways, the nose, but very important is that along with the upper airways, we have lower airways, and we more and more start to understand that there are diseases that are supposed to be together. For example, or that doesn't shine, but allergic rhinitis is much more linked to exercise-induced asthma and allergic asthma. And if, for example, we think about patients with chronic rhinosinusitis, especially with polyps, we very often see that they have a late onset asthma. So we start to understand much more phenotypes and endotypes of upper and lower airways and try to combine those two to understanding the patient as a whole. So let's look at some big data. There's a lot going on, and that makes our life complicated, because how much do you know about transcriptomics or metabolism or the microbiome? Whole new parts of our field that are quite complicated to understand and needs a lot of reading, but very, very important eventually for understanding things like sensitization to allergens, development of disease. So for us, there is a task to try to understand much more about all these different ways to analyze big data. Let's take a simple example in the ENT field, which really put a lot of discussion and thoughts in the last years. These are results from a large cohort which has run in the UK for a number of years. And I show you this example because I hope that it will encourage you to do the same. It was a simple cohort. They just said to all the doctors in training in the UK, whenever you do a surgery, you have to fill in a form, an online form. That's it. Very, very simple. But it brought a lot of very interesting data. And this is one of the examples. It's published by Claire Hopkins a few years ago. And what she did is she looked at different cohorts of patients with chronic rhinosinusitis and asthma. And she looked at patients that were operated early in the disease in the first year after the diagnosis, which is a miracle in the UK because it usually takes 2 to 3 years before a GP sends the patients to an ENT surgeon, a mid-cohort and a late cohort. Patients who had the disease, diagnosis of disease already for more than 5 years, but were never operated. And what you see here is that the patients who were operated early in the disease, that's the blue line, had an improvement in their SNOT score, but it remained perfect over time. You see they even increased a little bit. But the late cohort did almost as well in the beginning after the surgery, but you see in the years after, they deteriorate again. So apparently there is a window of opportunity that was lost in those patients. And they looked at how much healthcare these patients needed. And you see here it's a cohort of almost 1,500 patients in the early group and more than 1,000 in the late group. And you see that the patients who were operated early needed far less healthcare and made far less healthcare costs later in the disease. And, very important, developed asthma far less. So, by intervening early in the disease, it seems to be possible to prevent the development of late-onset asthma. And of course, we need now, this gives us an idea that this is true, and it has been shown in a US cohort too, the same figure, but of course we now need other more randomized trials to show whether this is really true. But things we would never have understood without using these big data. Let's look a tiny little bit about understanding of the pathophysiology. And of course, we all realize that the division, as we made 20, 30 years ago in chronic rhinosinusitis with or without polyps, is very mediocre. It doesn't help really to understand. We understand now that there are many phenotypes of this disease, that patients with cystic fibrosis have totally different polyps from an eosinophilic patient with severe asthma, that patients who live in underprivileged part of the world or in the East had almost always a neutrophilic, a non-eosinophilic polyposis, but now, because they change their way of living, their polyps become much more westernized. First ideas of how to understand different phenotypes and endotypes. Why is that so important? We'll show you later, and I will talk too much about it because I'm sure Professor Bousaba will talk about it, but it will change the way we treat patients. If all patients are operated anyway, it doesn't really matter whether they have a Th2 or a non-Th2 inflammation. But if you have different medication, it's very, very important. This was a cluster analysis we did in Europe in the Galen group, which is a large network of centers of excellence in Europe working on upper and lower airways. And you see here that we try to cluster analyze patients with chronic rhinosinusitis with and without nasal polyps. And you can see that there are very Th2. Can I move here? No. Yes. Th2 type inflammation, but also very non-Th2 inflammation. And it's not the same as polyps or no polyps, because here you see that although more patients with a non-Th2 do not have polyps, and here almost everybody has polyps, it's not a sort of clear division between these two. On the other side, the percentage of asthma, and you can see the more Th2, the more asthma. But also here, there are many different subgroups, and we only start to realize a little bit what subgroups are and how to treat those different subgroups. We know that we only have very little data, actually, but there are some data saying that corticosteroids are mainly effective when there is Th2 inflammation, when there are eosinophils, IL-5, IL-4, IL-13, mast cells, that makes that it is effective. And we know why, because corticosteroids can block many of these cytokines and mediators. And here you can see which they can block. And I could have put a lot more crosses than I did in this figure. Let's talk a little bit about big data and patient participation. Why is patient participation very important? On one hand, it's very important to empower our patients. It very much depends on the healthcare system you live in. But for example, in the Netherlands, only 10% of the patients with allergic rhinitis ever see a GP. The rest never go to a doctor. They go to their local pharmacist and get an antihistamine and live with it. And I think patient participation will be extremely important to explain to patients what they have, what their disease is, and that there is a lot to gain. And that they do not have to suffer with their allergic rhinitis or their chronic rhinosinusitis, but that they have to go and see a doctor who can help them. Here you see the allergy diary that is also developed within the Galen cohort with help of Mylan, which is now available in 16 languages and developed in 23 countries. And it does two things. One, it helps the patients to fill in their symptoms and see how they're doing and encourage them to say, hey, you're not good. You're in the red. You should be in the green. Do something. The antihistamine is not enough. Do something. Go to a doctor. On the other hand, it brings us an enormous amount of data. Imagine if 200,000 people fill in an app like this, what that gives us. And you can see here an example of more than 40,000 days where people filled in their symptoms, and where you can see that there is an extremely well correlation between whether you measure global symptoms or nasal symptoms, pointing to that the nose is actually the thing that gives the patient the most of the problem in the allergy. Also, you see here that the more symptoms the patient has, different symptoms, so the more rhinorrhea, for example, the more impact on activities, work, and sleep. All these data are not rocket science in that I say, well, I wouldn't have expected that to happen. But the good news is that it helps us to understand that what we think in our daily practice is really true for large groups of patients. Also now for rhinosinusitis, we developed an app. It's not yet in 23 countries, only in a few, but it will in the near future. And I use it in my daily practice, and it's really, really helpful. If I ask a patient, how are you? Oh, quite okay. So can I have your graph of the last 3 months? And I look at their phone, or I can look at my own computer to see what they filled in. And I say, well, you had a very bad period 2 months ago. Oh, yeah, by the way, I was in the hospital because I had an asthma exacerbation, and I took prednisolone, and I totally forgot. You know, so it helps to have the discussion with the patient on the amount of disease. Also in this app, there is an enormous amount of information, things like how to rinse your nose, how to use your medication, what is the disease, why shouldn't you smoke, etc., etc. So if we summarize this part, you could say that mHealth and apps have potential benefits for different stakeholders, primarily for the patient, definitely also for us, but eventually also definitely to do research, and eventually the two on the lower side, of course, the healthcare system and the society. There's also a bad side on that the healthcare system can potentially also misuse the data we collect, but it's up to us to try to prevent that. And then finally, of course, we all want better treatment for our patients. And I would like to draw your attention to the position paper we published on olfaction. And that was one of the small things, relatively small things, but really changed the way I treated patients in the last 5 years, was olfactory training. 5 years ago, when a patient came and said, well, I lost my smell, I said, bad luck, you know. You do an MRI if you feel very worried. You give some steroids, it doesn't help, and then you say, yeah, that's life. Now, we give patients a daily training with odorants to help them to improve their smell, and it works. And it works objectively. Thomas Hummel did nice studies where he really measured with olfactometry that the patients did better with their olfaction, but maybe even much more important, the patient felt that they could do something. It's much better to say, when your doctor says, well, start this training and it will improve, than say, well, bad luck, can't do anything about it. So it changed my practice in a positive way. Finally, if we look at chronic rhinosinusitis, and I hope you all know these treatment schemes for measles, but what was very bad about these schemes, and we will do better in 2020, is that they all ended up somewhere in the right corner with surgery. And many people said to me, okay, I did the surgery, and the patient's still not good. What now? And that's something we left it out. We planned all this, but it stopped there. So now I think for the next time we're going to think much more in control of disease. So after the surgery, if the patient is well, we're going to taper down. If the patient is not well, we're going to increase our medical treatment, do revision surgery, whatever is necessary to get the patient well. And this scheme will tremendously change in the coming years. I'm absolutely sure that we will go away from steroids and surgery to other possibilities. I showed you this graph of Th2 inflammation that can be blocked by steroids. And also in the non-Th2 inflammation, all sorts of new medications are coming, anti-IL-17, anti-CXCR2. But especially in the Th2 inflammation, there are all these new monoclonals. And I don't show you any of the studies because I'm sure the speaker after me will probably do that, but I will show you a little bit of why they're so great. Here I compared them to systemic steroids. You can only give them in short courses. They're very effective, they're very cheap, but you can't give it year long. Well, you can, but then the patient is back after a few years with hypertension, diabetes, or in a wheelchair because of the osteoporosis. These new biologicals are as good, I think, as systemic steroids, as effective in Th2 disease. At the moment, they're extremely expensive. Here in Europe, something like 10 to 15,000 euro per year. In the US, it's even worse. but that will go. That's a problem of today, but it will not be a problem in 5 to 10 years. In 5 to 10 years, this will be something you normally prescribe in your severe polyp patient, and it will extensively change our daily work. We will not do that many revision surgery anymore, probably once to open up the sinuses, and then we will go in this direction. And to understand which monoclonal to give, what to do, you need to understand a lot more about the pathophysiology, whether you like all the arrows or not. Biologicals seem to be very safe, by the way. So this graph will change. It will be something like this. Maybe revision surgery, but much more often we will move to biologicals and treat our patients that way. This is a new cartoon we recently published in Allergy, where we said, well, you could argue that polyps is probably not so important. Probably the phenotype polyp is an ending story. And here we still did both polyps and eosinophilia. But you could argue that probably the eosinophilia is much more important than the phenotype polyp. And that in due time, we will all take a simple sample, and I don't know yet whether blood eosinophils will be enough or that we really need a scraping or a biopsy. We still don't have those data. But that will decide what sort of treatment we're going to give. Not anymore whether it's a polyp or not, but what is the inflammation that we see there. Last 2 slides, just to show you something else than chronic rhinosinusitis. Of course, this changed for our patients enormously, the patient with cystic fibrosis. I still remember this girl who came to me and said, here you see her first name, version 2.0. She had terrible lung function, 30%, was going right into a lung transplantation, and her sinuses always looked like the sinuses on the left. And after 6 months of one of these new CFTR protein potentiators, here it was Calideco, she was another person. Her lung function came back to 60%, her sinuses were normal. So an enormous improvement for these patients. At this moment, there are now a number of these new medications. This is the newest kit on the block. It's a combination of lumacaftor and ivacaftor. It's still only for a limited part of our CF patients, but a new one is produced every year almost. What's not ideal yet, and where we have to work on, is that these sort of publications only look at the lower airways. And where can you find something about the upper airways? In the side effects. So that's something I would like you to do better, that we're not in the adverse events anymore, but that we are a part of treating patients with cystic fibrosis, and that we can explain that the upper and the lower airways are both a very important part of their quality of life. I will skip this. So, guidelines will change. When I was young, the guidelines changed from opinion-based. I just had a little bit of that, you know, going with a group of people who all knew each other to a nice hotel somewhere, and then having nice discussions for 2 days, and then they looked around the corner and said, oh, you're the youngest, you write this up. And that was the new guideline. Now, then we got the evidence-based guidelines. The last 20 years, in all parts of our field, we have evidence-based guidelines. But now, again, there will be an enormous change, because we will, the next 20 years, I'm sure we will go from these evidence. Evidence will always remain extremely important, but we will understand that evidence collected from large gatherings of very variable patients is probably not the ideal way to treat a patient, and we will go to more precision medicine, personalized care, and try to predict how the patient will react to our management with the possibility of prevention and patient participation. So already for 20 years, I dream that one day there will be this little handkerchief that I can give to my patient, and he blows his nose, and I put it in a computer or in a nice machine, and the machine will tell me exactly what the patient has and how we're going to treat him. We're still far from that point, but much closer than 20 years ago, and I'm sure that in 20 years, many of you will still be there to see that this is really an option. I told this earlier this afternoon, and again would like to finish with inviting everybody to Thessaloniki. Thank you very much. And then I would like to introduce Professor Nicolas Busaba from Harvard University, and he will talk about advances in the medical management of chronic rhinosinusitis.
Well, thank you for the invitation, and thank you for the chance to visit the beautiful city of Belgrade and of seeing many of the friends again. I'll be talking about the advances in the medical management of chronic sinusitis. It looks like Professor Falkins had many of the same of the same slides, so there'll be a lot of overlap in our talk. In the first half, I will go over an overview of the management of chronic sinusitis with nasal polyposis, and then in the second half, I'll tell you our approach, our research, as led by Dr. Blyer at my institution, looking at different way of controlling inflammation through controlling one of the chemicals involved in the inflammation. For those of you who don't know Boston or who have not been to Boston, this is my hospital here, the Massachusetts Eye and Ear. So the reason we're talking about advances in the medical management of chronic sinusitis, when I did my training from 90 until 95, endoscopic sinus surgery in the United States was at its infancy. At that time, we thought that endoscopic sinus surgery can cure all cases of chronic sinusitis. It was thought that it's mainly an anatomic problem, do surgery on that OMC region, and then all patients will be cured. But then we realized that actually it's more of an inflammation, more than an issue of, anatomy plays a role, infection plays a role, but it's mainly inflammation. And that many cases you do surgery on, and then after 6 months, they'll be back to square one. There are patients, for reasons we don't understand, severe disease, you do surgery once on them, and they are good for life, and there are others, as I said, you see them a few months later, and as if you have not done much on them. And therefore, I see surgery more as an adjunct to medical therapy. This is what I tell my patients. I tell them, we'll do surgery. Chances are you will still need to continue medical therapy after surgery. The aims of the surgery, they can improve it can improve the symptoms, it can decrease the disease load, but it can also improve the delivery of the medications to the target sites. So the other issue with chronic sinusitis is that it's not a single, do you have the line? Yeah. Very faint light. It is not a single problem. It can be genetics, it can be allergy, it can be impaired mucociliary clearance, it can be infection, environmental factors, impaired epithelial defense, immune dysfunction. So it's a multitude of variables that all lead to chronic sinusitis. And to just think of a simplistic model does not work. And there are different pathways of inflammation. The most common in the nasal polyposis cases are the Th2 inflammation. But then you can also see, IL-33, IL-25 working through the innate immunity on the left side of the screen, which then lead to which can the innate cells can become Th2 cells, and then they can produce IL-13, IL-5, IL-4, leading to the other products which can lead to inflammation. And then on the right half of the screen, you can see the infectious part. the easier to control part. So it is a, multiple pathways, but those that are most difficult to cure are those who fall in this center here, where these two pathways meet with these inflammatory mediators and then leading to the disease process that we know. This is the same slide that Professor Falkins showed. What I like about this is that the upper part of the slide, those will with IL-22 and so on, these are in my mind at least easier to treat, easier to cure than the lower part. The lower part are the most frustrating. The lower part are the reason there is so much research happening in biologics, and there is so much investment and technology being poured into it, because the lower part, the IL-5, the IgE, that pathway with severe asthma. These are patients who are very morbid, severe asthma, severe polyps. You do surgery on, they fail. And these are the ones that we need to help mainly with the newer medical approaches. In the past, when I did my training, these were the options. And these are still good options. And many patients, the majority of our patients actually, are in one of these options. Steroids, topical, is the mainstay of therapy. Sometimes we give short courses of oral steroids, antihistamines for those who have allergy, antibiotics for those that there is superimposed infection or we think there is a biofilm and so on. Immunotherapy for patients who have documented allergy. But don't forget about the importance of saline irrigation. I think it is as important as the medications. And I tell my patients, you have to do it at least every day consistently, and we tell them to use distilled or pre-boiled water. And at least at my institution, many patients are on the budesonide rinses, even though this is not FDA approved for sinusitis, but we believe it's more effective than the commercially available steroid nasal sprays, but it is cumbersome. Some patients don't like it because of the way they have to position their heads. I believe because the dose is not controlled, there could be a slightly higher risk for glaucoma. So I tell the patients to make sure that they see their ophthalmologist every 6 months to a year so that they can check the intraocular pressure to be sure that they don't develop glaucoma. Now, we moved, as the previous speaker said, we moved from a phenotype-based treatment to an endotype-based treatment, or we are trying to move, I should say, trying to move to an endotype-based treatment. So in the past, we used to say this patient has allergic rhinitis, this patient has infectious chronic sinusitis, this patient has chronic sinusitis with nasal polyposis, and then we will treat them accordingly. Now we are looking more at the inflammatory mediators, at the IgE, at the aspirin-exacerbated respiratory disease, at leukotrienes, at IL-4, IL-5, IL-13, IL-17, and then I'll show you our research with the P glycoproteins, which is our focus. So I did this study with my colleague back in 2005 using montelukast, oral, very cheap, 1 pill a day. These are patients who were on steroid nasal sprays with persistent nasal polyposis before surgery, and then we added montelukast for 3 months. And then we tested them. And as you can see, the reason I'm showing this, because I will show you later data about the biologics, and unless you can improve on that outcome, the question becomes, is it worth spending all this money on these biologics? The biologics in the United States, they cost around $30,000 US a year. So unless you can significantly improve the outcome, it could be hard to justify the cost. So here, as you can see, if you're looking at symptoms, adding leukotriene to these patients, those with allergy symptoms, around 80% of them improved over what they were doing with their topical steroids, and around 60% if they had non-allergic rhinitis. And then we looked at the tissue eosinophils on those patients who allowed us to biopsy the nasal polyps in the office pre-treatment and then post-treatment, and looking at the score of their tissue eosinophilia. Again, you see significant decrease in their tissue eosinophilia with just adding montelukast. The response was more dramatic in the allergic group, but it was also noted on the non-allergic group. At that time, we did not do more in-depth research, so we did not look at the overlap between these two groups, as in the slide I showed you before. So both groups, the allergic and non-allergic, could be having a Th2 response with IL-5 related response, even though clinically they are behaving differently. Now, for those who have aspirin exacerbated respiratory disease, since the first paper was published from the Scripps Clinic, we are offering it more and more to our patients. Most patients don't have to be admitted. The target is 325 milligrams BID, but sometimes some patients will need to go up to 650 milligrams BID. So I will share with you one of our patients. So you can see the pre-op and pre-treatment CAT scan. You can see the patient had pansinusitis with nasal polyposis. We did endoscopic sinus surgery, and then we put the patient on a regimen of aspirin desensitization combined with xyluten, which is a leukotriene inhibitor, as I said, and as well as the surgery. And what you can see, upper one is the right nasal cavity, right sinus cavities. Left one is the left nasal cavity, lower one. And you can see the patient did very well. Again, you see the ethmoid mucosa is very healthy. The maxillary antrostomy and the maxillary mucosa is healthy. The sphenoid is open. So we think that the main advantage here was doing the aspirin desensitization, adding it to the conventional therapy, adding it to the endoscopic sinus surgery and the xyluten. But the prevailing wisdom is patients need to have sinus surgery before you can start the aspirin desensitization. This patient refused surgery. So she said, let's try, so I sent her to the allergy immunology team, and they said, let's try just, doing the aspirin desensitization without surgery. And as you can see, this is, on the left side is the pre-treatment CAT scan. On the right side, you see still images of the upper one is the left nasal cavity, right one is the lower one is the right nasal cavity. And you can see her disease is very well controlled, markedly improved without surgery. So at times, I'm not saying that every patient should have aspirin desensitization without surgery. I think it's better if they have large polyps, high volume load, is to do surgery before. But at times, patients can do well without surgery, as evidenced by this case. Next is the anti-IgE antibody, omalizumab, and it is in a subset of patients, those who have documented elevated serum IgEs, documented allergens, with severe asthma, they do very well. It is injection. It is every 2 to 4 weeks. It is very expensive, but it is approved for those with significant asthma. There are no medications as of now that are indicated for nasal polyposis. So as of now, no company was willing to, has conducted, some are doing it now, has conducted studies so that they can get FDA approval for nasal polyposis. So most of these are actually approved for severe asthma. And this is a classical patient, multiple previous surgery. The patient has recurrent nasal polyposis, very severe asthma, and you can see his disease. So we did revision surgery on him, and now he is on anti-IgE, and you can see how nice his cavities are. So again, not every patient does like this. Obviously, I'm showing you the best cases. So these are the cases that did the best. Next is, we realized that IL-5 is a big player in Th2 inflammation, because it is very critical in recruiting and stimulating and activating eosinophils. The one which is more available now is mepolizumab, and it blocks the IL-5 receptor, and the aim is to decrease the tissue eosinophilia. The paper, the original paper was published in 2011. I am aware that there are more studies happening now, both in the US and in Europe. But when I look at the outcome, at least in this paper, I am not very impressed. I mean, yes, 12 out of 20 patients did well, but these are pre-selected patients, and yet only 12 out of 20 did well. Only 1 out of 10 on the placebo. So it makes you wonder, is it worth all the money? This is a patient of ours who has severe asthma. Again, the indication for using this medication was not the nasal polyposis. The indication for using the medication was the severe asthma. As a benefit, as a byproduct, their polyposis can improve as well. So this is, on the left side, you see the pre-treatment, while on the right side, you see right nasal endoscopy showing post-treatment. So there are still some polyposis in the frontal recess. The ethmoid lining still looks mildly polypoid. But overall, if you can maintain this patient in this condition, you don't have to revise the surgery. You don't have to have more surgery performed on this patient. But this is rare outcome. I have maybe 10 patients on this medication. I'm happy with half of them. The other half, I have not seen that much benefit, even though this is, a proven tissue eosinophilia by biopsy at the time of the endoscopic sinus surgery. Still, the benefit, the result is not as impressive as you would like them to. Dupilumab is a more promising treatment because it blocks both IL-4 and IL-13. And IL-13 is very important in multiple of the end pathways leading to goblet cell hyperplasia, basophil, the cell membrane, and so on. This paper was published in 2016, looking at the outcome. Looking at the outcome. So when you look in there, the authors started with 60 patients. Already 9 were lost. What happened to these 9? Were they failures or just lost? I don't know. But then if you look at the other remaining 51 patients, yes, overall, the primary outcome of decreasing the polyp score improved. SNOT 22 scores improved. Their smell improved. But then you look at how much SNOT scores improved, 18. I know that the minimum clinically important difference is 9 for this SNOT 22 to become relevant. Here it is 18. But still, if you think about it, if you ask the patient, patients still have symptoms. So patients still have symptoms. And there is always this question, how effective, how much are you adding to the existing treatment in terms of controlling their sinus disease and their nasal polyposis? This led us to think of it differently, and this research is led by Dr. Blyer in my department, saying, can we block multiple mediators at once through the P-glycoprotein pathway? So P-glycoprotein is present in the respiratory epithelium in many organs, in many parts of the body, but it is also present in the sinus epithelia, in the maxillary and in the ethmoid epithelia. And what it does, it helps transport the inflammatory mediators, these exosomes. So it helps transport them into the tissue, into the sinus cavities, leading to the inflammation, IL-5, TSLP, IL-6, and the granulocyte monocyte colony stimulating factor. And then we know that this is overexpressed in patients with chronic sinusitis. And therefore, there is overactivity, there is over-release of these mediators. So the question becomes, and this is happening in the ethmoid and maxillary. So the question becomes, if we block this P-glycoprotein, how much can we help these patients by preventing the release of these inflammatory mediators? So there are 3 generations of increasing potency. We decided to go with the first generation. It's commercially available. It is very inexpensive. You're talking about few dollars a month instead of $2,000 or $3,000 a month. And we chose the dose of 80 milligram POTID because this was indicated for cluster headache. So we knew it is safe. We knew it will not cause any serious side effects. So we decided to start with that dose. So this is a double-blind, placebo-controlled, randomized trial. Patients were asked to be off any form of steroids for 4 weeks, be it oral or be it topical.
Can you?
Almost done.
Okay.
And then we started them on verapamil, as we said, placebo versus treatment arms. And then we looked, the primary outcome was the SNOT 22, but then we looked at secondary outcome, the Lund Kennedy score and the Lund Mackay score as far as the CT and endoscopy scores. And this is how we recruited them. We ended up with 10 patients in the treatment arm and 10 patients in the placebo arm. And this is what you expect for the minimum change in SNOT to be clinically relevant. Again, placebo, we did not notice much difference. But on those who are treated with verapamil, we noticed benefit within 2 weeks, and this benefit continued to progress through week 8. And that was in the SNOT 22 score, as well in the visual analogs score. And you see the benefit progresses through week 8. And then if we looked at the particular domain, smell and congestion improved the most, while things like drainage did not improve as much, and sneezing did not improve as much. And then when we looked at their CT scores, there was significant improvement in the treatment arm compared to the placebo arm. When we looked at their nasal polyposis endoscopy, there was a significant benefit by week 4, but then we lost that benefit by week 8. So there was a relapse. And then, so this is a classical patient. This is a quick video. So this is a classical patient. You see the improvement in the subjective symptoms. You see CT pre and then CT post treatment. And then you look at the endoscopy findings. You saw it at baseline. You'll see it now at week 2. You start to see some improvement. Then you will see more improvement at week 4, and then more improvement at week 8. This is not universal. This is not the entire 10 patients, but it is impressive that these are patients off steroids. The only treatment is verapamil. They have extensive nasal polyposis despite previous surgery, and then you can see the degree of improvement over this 8-week trial of therapy. And then we thought, this last slide.
I got the message that I have to stop you.
I know. Last slide is that we found out that BMI is a big factor. So now we are looking at a higher dose. We are looking at topical versus systemic. In conclusion, verapamil, we think of it as promising for the treatment of chronic sinusitis with nasal polyposis. We think 80 milligram TID is subtherapeutic. We are looking at different dosage now. We are looking for, what our data, it supports the role of P-glycoprotein in the pathogenesis of chronic sinusitis. In summary, biologics are very promising, but as of now, we have still not being able to identify biomarkers that can help us select patients for treatment, predict response, and then monitor success. In summary, so I still rely on the main treatments. If they fail, I add leukotriene inhibitors. If they fail and they have significant asthma, extensive polyposis, then I start thinking of biologics, be it IgE disease, then it is anti-IgE, be it central triad, aspirin desensitization, and then there is also a role for anti-IL-5, anti-IL-13, anti-IL-4, and we think there is a role for P-glycoprotein inhibitors. Thank you.
You want to? Huh? Yeah. The next speaker is Christos Georgialos from Athens, talking about skull-base reconstruction and CSF leak management.
Thank you, Vitska, and I would like to thank both Alexander and Liliana and Professor Jovic for the very kind invitation. And I will try to make up for, I will try to be on time, and I promise I will not, it will not take me more than 15 minutes. Just 1 second, because I think I left my... So I really liked both previous speakers, and they gave a very beautiful overview of both the future of rhinology and the more, let's say, scientific parts of our profession. And I'm afraid my talk would be much less, let's say, creative in that way. And I will be dealing more the more mundane, more practical issues that we have to deal with, such as how to close holes, a more practical issue. But I will be drawing from both my experience and the mistakes I have made, also the mistakes that other people have made and have landed on me. Probably my mistakes have landed on other people's practices as well. And 4 specific issues I will be dealing with. When is being old, is too old, when someone needs an operation for a CSF leak. What about shunting to reduce the intracranial pressure? Could be a substitute for closure of CSF leaks. How to find them, and how to understand how they occurred. And talking about the patient that one of the first patients I saw when I was referred to me when I arrived in Athens, 81-year-old, following 2 phases in Cyprus and in Athens, and one of the, unfortunately, not so uncommon side effects of this operation, a constant left-sided rhinorrhea. You can imagine what has happened. And then one of these ENTs would keep on seeing the patient and advising outpatient polypectomies. He would actually advise him that when he gets a cold, he should take antibiotics to prevent meningitis and keep on treating him like this for a few years. And the idea was that he was too old to get a reconstruction for his CSF leak. Eventually, he had to refer him when the patient presented with reduced vision, as well as water rhinorrhea. And the reason for the reduced vision, I think it's easily understandable if you look at his MRI, which beyond, actually the most impressive part is not the encephalocele that you can see there. Let me show you. You can see here, if it's working, sorry. Anyway, it's not the encephalocele that you can see here. It's basically that it has caused a secondary mucocele in the sphenoid sinus that you can see there. It's pressing on the brainstem, and obviously laterally it's compressing the optic nerves, which has caused the subsequent loss of vision. So the actual procedure, although it was referred to a neurosurgeon, the neurosurgeon referred it to us, and the actual procedure was not so complicated. The mucocele, as always happens, has done most of the work for me, so once they were drained, then the non-functional part of the encephalus of the brain was cauterized, and the closure was done with a piece of fascia lata, so the cautery of the tissue of the non-functioning encephalocele, and then the closure with the fascia lata, and then another layer of fascia lata, and then the flowcele. And this was the post-op result, and really, for the patient, it was not a big deal. He was discharged 2 days later. He has been free of rhinorrhea, and this was the last follow-up just a few months ago. And of course, there was very little bone left in the skull base, so you can see the pulsations, you can see nicely the frontal. Most impressive is still the sphenoid. It's almost like an anatomical specimen where you can see nicely the optic nerves, the clivus, the carotids. But there hasn't been a CSF leak. His vision improved, and the patient has been fine and at home. Secondly, shunting as opposed to closing. This was this was a young guy, actually, much younger. But for many years, he has been diagnosed with encephalocele. It's a complex story. He had an operation, a globe removal for Koch's disease. And there was one attempt done transcranially to close it at the age of 12. And then there were no further attempts at closure. But he had twice, excuse me, an attempt to deal with encephalocele by reducing CSF pressure. He had CSF diversion shunts twice. But in the meanwhile, he kept on having meningitis. He had 4 episodes of meningitis in 20 years, but the last one, the one that caused the referral, he was in 1 month in intensive care, had a tracheostomy, and he was in coma. So in total, 18 years of CSF rhinorrhea. And this was his both endoscopic view, and you can see also on the CT and the MRI, quite extensive encephalocele. It was actually touching the floor of the nose. You can just around get the endoscope past the encephalocele and go posteriorly to the nasopharynx. But again, it may look very impressive. It's not a problem. The closure, like we create such defects when we do a transcribiform approach. We create larger defects than that. So what works in most of these cases, fascia, what works in my hands, and some people may do it differently, of course, but fascia lata underlay, a fascia lata overlay, and then a nasoseptal flap. The nice thing here is you don't have a malignant humor, so you don't have a limitation in using the nasoseptal flap. And that was the result. So you can see the endoscopic view of the healed skull base and also the imaging following the repair. So obviously sanding cannot be a replacement for dealing with these cases. Now another patient operated, this guy has been operated many times for a CSF leak. And I spoke with a surgeon actually, who's a very good surgeon, and he kept telling me that the CSF leak would recur every time from the second or third day. And he was thinking of removing all the mucosa and just plastering it with a nasoseptal flap, or referring it to the neurosurgeon. Actually, at the end, he did refer it to the neurosurgeons, who then referred him to me. Now, this is the scan of the patient, and I really want you to look very, very carefully, because you can see, obviously, the previous surgery. You can see that the septum is missing as part of the harvesting of the flap. You can see there has been some extensive surgery done, antrostomy. You can see the middle turbinate has been medialized. There are quite some cells in the anterior and posterior ethmoids. But where is the leak? It's not very straightforward, but you can see this area just at the attachment of the left middle turbinate, that something looks just not right. You cannot prove it. You cannot put your finger that there is the leak coming from, but that could be the case. So then you want an MRI. And then you look at you want 1 millimeter slices, and usually in my hospital we ask for gamma knife protocol, because otherwise they will do 3 or 5 millimeter slides, which are useless. But with 1 millimeter T2 cis slides, you can see here that certainly there is CSF leak exactly at the location which looked suspicious on the CT. So bringing this together, bringing these two pieces of information together, the CT and the MRI, you can actually visualize the leak. The report is useless. That's the report from the radiologist, suggesting there is no evidence of defect. So from the two together, you can see where the location is, and then you realize the reason it was never closed was not because the leak recurred, because it was never closed in the first place, because no one went there. You see, all the operations were done laterally to the middle turbinate, while the leak was medially to the middle turbinate. And indeed, that was the case. Then the surgical part, I'm not going to bore you with, was pretty straightforward, doing a wide ethmoidectomy, because I want to have space to go laterally, including here cauterizing the anterior ethmoid artery, and we'll go a bit farther. And then once this is exposed, then removing part of the middle turbinate and lateralizing, and then you can see the encephalocele, the very small encephalocele, which then can be closed. In this particular case, it was tiny. That's why you couldn't find it, actually. It was a couple of millimeters. So what I used was just a simple piece of middle turbinate mucosa, which did the job. It was confirmed with navigation, of course. And then the closure. You see, with these small defects, even when you cauterize them, they start closing up. The leak will stop. And it's not the closure the problem. It's not a big defect. It's actually making sure that you have found them. And people will talk about fluorescing, but I think that it's much more useful before the surgery, where you have the time and you have the state of mind to be very careful and very precise, to look at the CTs and the MRIs, and to really ask for 1 millimeter CT scans, 1 millimeter MRIs, take them side by side, and make sure that you know the leak before you go into theater. And that's the post-op results, not a problem. Very similar story. Also, in this case, an overweight female, 5 months rhinorrhea. In this case, he was advised for a reason I'm not sure with 3 months of bed rest with the idea that it will stop. There was no sign of leak visible on CT and MRI. That was the reports from the radiologists. And then again, looking at carefully asking for another MRI, 1 millimeter or even less than 1 millimeter slide of MRI. And then you can just about see an area there on the left side. It's tiny, it's millimeters. There are small leaks, right? These patients may have multiple areas of defects, and you will not know for certain if you just had one cut. But then in the outpatient, actually, you could visualize the area, just about visualize. You can see here on the bottom where the CSF leak is CSF is running down, and if you just push the middle turbinate, that was in the outpatients, you can just see the tiny encephalocele. And once you visualize, this is how it looked, of course, if you come out close and personal and you see it pulsating and you see the CSF coming out. Once you find them, the closure is not a problem. In some ways, it's similar to mucoceles. The bigger the mucoceles are, the easier they are to deal with. The very small mucoceles are the ones you may have trouble dealing with or closing or opening up. So anyway, once it was found, then the next steps were not difficult. the closure again with in the usual way. In this case, we use some fat, and then a piece of fascia lata, and then also mucosal graft. And this is 3 months post-op. So we talked about the small, difficult to find areas. We talked about the big ones, which may look impressive, but actually for the patient, treating them will give him a significant bonus, and it's not necessarily so intervention as it looks. And then the fourth one is that things happen for a reason, that in patients where there's no obvious reason for a CSF leak, you must think why this happens. And
Christos,
I'm
this
finished
is 15 minutes.
15, fine, thanks. So, final story. Anyway, I'm not going to go about the details, but this is a typical patient which leaks, and then the scan, and the small leak. What I want to talk about this here is the patient had an empty cella. So she was measured before the surgery, the ICP was normal. But of course it would be normal because she was leaking from the nose, so it wouldn't be elevated. And then she was repaired, and finally, after closure, we gave her acetazolamide, and then we measured the CSF pressure. It was 39 millimeters. It was more than double the normal rate. And then she had the sun, and it has been dry. So, my final slide, to take home messages. Number one, idiopathic. When you look at a patient that leaks without a reason, think why this is happening, and look very carefully at the MRI. And you're looking at an empty cella, which you can diagnose in the MRI. You can find. You can look for arachnoid pits, which you can find on the lateral part of the skull base. You can look at enlargement of the skull base foramina, the widening of the subarachnoid space, also the enlargement of the dural sheath around the optic nerve. All this show that there is an evidence of there is increased intracranial pressure. And unless you treat it, you will not be able to cure the patient. And then finally, think about, before you operate, to examine carefully the CT and MRI that you have, so make sure that you identify the location of the leak before surgery rather than later. And think about optical coherence tomography, because that will help you identify early changes in the optic nerve. And of course, shunting is never a substitute for closing a leak. And I would like to invite you both to the 6 endoscopic skull-based course we are doing with Wouter van Vuth, the neurosurgeon in Leiden, hands-on, or also the Santo Rhino, which will be a lecture-based meeting in Santorini Island at the end of September. Thank you very much.
Thank you, Christos. The next talk is from Professor Scheithauer, State of the Art in Cleft Lip Rhinoplasty.
No, laser doesn't work on the LED screen.
Well, thank you, Madam Chairman. Ladies and gentlemen, dear colleagues, in the next 15 minutes, I would give you a brief survey on modern but reliable operational techniques when you consider to operate on cleft lip noses. But first of all, I would like to give you a presentation of the severe anatomical problems these patients have. And first we start with bony deformities. And if you remove the soft tissue envelope, you see clearly what is the problem here. On the cleft lip side, you have a severe narrowing of the piriform aperture. And what strikes us secondly is that the floor of the nose on the cleft lip side is much lower than on the healthy side. And this has an effect, of course, on the cartilaginous pathology because it tears down the cartilaginous complex of the caudal septum and of the nasal tip. As you can see here, again, the problems without the soft tissue envelope. You see the lower lateral cartilages on the left side, the cleft lip side, the three-dimensional displacement of this cartilage. And this gives us, in the operation room, the problems to get these things properly done and create normality. You all know the typical stigmata of these patients, starting with the outer nose. You have the pyramidal asymmetry, you have a bifid tip, and you also have a whistling deformity if you see the lip of the patient. And sometimes I also do a correction here too if the patient wants it. The functional problems, however, come from the depressed domes and the lateral cross, as I said before. The alar rim is very long and flat. The columella very short, retracted, and very broad. And the typical problem which you have to recognize if you make an analysis of these nasal bases is the vestibular stenosis, which again comes from the narrowing of the piriform aperture. Now the goals of this sort of rhinoplasty is quite simple. We don't want to create a perfect nose. This is impossible. We want to create normality for these patients. And the surgical techniques are only based on the pathology we find before the operation. And we have two problems. We have a cartilage, which is normal, but it looks displaced, and then it's quite easy. Then during the operation, you have to mobilize cartilage, and especially the lower lateral cartilages, and repositioning them. Much more difficulties you see if you have a lack of tissue and the tissue is displaced simultaneously. Especially have a look at the vestibular stenosis, at the narrowing of the nasal entrance. In this case, the technique must combine a mobilization, a reposition, and the implementation of grafts. Now you can see a very easy problem. Cartilage is normal but displaced. In this easy case, I would say you will succeed with mobilization and repositioning. So you do a septoplasty, as you all know it. Then you release the complete side of the lower left cartilage on the cleft side, suture it if you have the wanted situation, and at the very end, I always do the osteotomies. And with this, I would say easy technique, you can create a normal nose. A bit more difficult case with lack of tissue and displaced tissue, as you can see here. There you, as I said, you had to think about grafts. And in this case, a full thickness skin graft is needed, and you can put it in where the skin of the vestibular is missing. If you don't graft this region, you will get a scar again, and you will have the same problems as before. The green space shows the place where you have to put in the skin graft. An even more complicated case is shown here. And in this case, my teacher and mentor, Professor Rettinger, published an interesting study about replacing and reconstructing this part of the nose where you have the defect in the lateral side wall of the nasal entrance with a composite graft, because it serves the cartilaginous part and the skin part for stability and epidermal resurfacing. Again, the sequence, mobilization by an open approach in these complicated cases, of course. Septoplasty, because you want to have a stable central pillar. Repositioning of the complete release of the lower lateral cartilages. And then, which is the most important part of this operation, is opening the vestibular stenosis. And in the very end, again, the osteotomies. On the left side, you see this vestibular stenosis, which we call the plica vestibularis. And on the right side, you see the reconstruction after opening it with this composite graft. Where I come from, I was told to get this graft from the cavum conchae, from the auricle, and we take it from the frontal part and reconstruct the defect then in the frontal part of the auricle with a retroauricular island flap coming from the skin of the mastoid. Which is important is that you have circular splints left in for about 10 days, because it's a free transplant with no perfusion at all, so it needs compression. And after these days, we remove the splints and put in custom-made stents, which are made by one of our dentists. We leave them in for about six months per night, every night. And this is, I think, a very, very interesting new technique, which I owe one of my friends, Holger Gassner from Regensburg, who invented this foundation graft. It's a rib cartilage, as you can see. It's about 4 centimeters long. It has to be quite stable in shape. And you also start with the septoplasty, open approach, of course. Then you release completely the lower lateral cartilage from the vestibular skin. Second step is to get the domes in the same position, in the same height, with suturing. And now the foundation graft comes into position. It is inserted in between the layers of the lower lateral cartilage and the vestibular skin and positioned on the piriform aperture with a slight bending, of course, as you can see here. After suturing it all together, it looks like this. And this is a really stable and good condition for keeping the cartilaginous problem of the cleft side in position not only for months but for years and years. Now we have the same problem again with the skin defect. And in this case, I do a Y2V-plasty. I don't insert any composite grafts or skin grafts anymore. In most cases, a Y2V-plasty is enough to close the skin and give this defect a certain length, of course. This is just one picture as a result. And if you have a close look to this region, I always find it very anesthetic, not harmonic, if you see the nasolabial angle of these patients, because the maxilla also produced this problem and also use premaxillary grafts to harmonize this special nasolabial angle. I have enough cartilage because I always take rib cartilage for this, and before I throw it away, I insert it in this position. A complete different problem is our patients with bilateral cleft lip rhinoplasties. Then it's not enough if you make just a septorhinoplasty, as I told you before. In these cases, you have to analyze and find out that the columella is very, very short. And the best results you get if you are able to lengthen the columella. And in my point of view, as you know, there are lots of techniques described in the literature. The Gillis fork flap is the best and most reliable technique to lengthen the columella. The skin comes from the upper lip. As you can see, it looks like a fork, giving this flap the name, the fork flap. And you can transposition this skin from the upper lip into the columella. It's lots of suturing then. You have to be really careful. Among smokers, you get really high problems with necrosis, so I don't operate on smokers in these cases. But the results are quite satisfying for the patients, I think, to give them a normal aspect of the nose again. So to conclude, and I hope I'm being in time, Madam Chairman, you see this kind of surgery is technically quite demanding. You always have to think about grafts and the special grafts in these different problems. Think about stents if you need grafts, because they are free transplants. And in my point of view, one unsolved problem, of course, is the symmetry of the nostrils. And I did a study a couple of years ago where I asked my patients about the post-operative subjective results. And astonishingly, they ranked the aesthetic result better than the functional result. So I hope this does not make me a bad rhinosurgeon. And thank you very much for your attention.
Thank you very much, Professor Scheithauer. And the last but definitely not least, and the only one from Serbia, Professor Jovic, talking about malignant tumors of the sinonasal region.
Well, dear colleagues, there is many traps in attempt to present the results of treatment, the tumors of the sinonasal regions. There is many difference in this region. First, there is a difference according to the sites of origin. The most often origin of the tumors is maxilla, maxillary sinus, and the second place is nasal cavity. But in the great number of the cases, like in this, the cancer catch 2 compartments or 3 compartments, and in these cases it is very hard to say what is the true origin and how to present this cancer as the cancer of the maxilla or the cancer of the nasal cavity. Then the wave of spreading is also different. In the upper part of this region, the cancer spread toward the endocranium or orbit. In the lower part, it can spread toward the pterygomaxillar fossa or infratemporal fossa, or over the lymphatic vessels into the neck lymph nodes. Also, there is much of the differences, and if you compare the results, it is very hard to compare the different group. Then, the histological types is also different. There is a lot of the squamous cell carcinoma, about 80%, and the carcinoma. But another form of the tumors are really rare, and some of them I saw only once during my career. And the next is difference according to the size of tumor, and that is the most important. If you plan to resect the cancer, you will resect the different volume and make the reconstruction different kind of the space, and finally functional results is also a little bit different. According to the Serbian Cancer Registry, the cancer of this region is very rare. In the nasal cavity, we have 0.1 new cases every year, also in the maxillary sinus. And if we look at the incidence of the cancer in this region, incidence in the nasal cavities is 0.2, and in the maxilla 0.1. That means this cancer is rare, represent less than 10% of the head and neck cancer, and it is more often in the male. In elderly ages, and very rare in the patient less than 5 decades of the life, in the both groups. As you know, there is a 3 stadium in the development of the disease. First is asymptomatic, and this stadium is resembled to the chronic inflammation of this region, but unilateral signs of the symptoms with nasal obstruction, epistaxis, and bloody discharge from the nose. And if you have some of these symptoms, it is very important to think that maybe there is some malignant tumors. Then, when the tumor grows, he will first the empty space, but after that he will make the deformity of the bony structures, deformity of the face, and there is the symptoms of the deformity of the bony part, loss of the teeth, diplopia if they go to the orbit, proptosis, or go to the alveolar process with a problem in this region. And finally is the destructive process with the involvement of the endocranium, brain, or toward the orbit, and produce the problems with the vision or with great skin exudation. We know that the clinical exam is extremely important, and now every, I think, institution possesses the endoscope, which revealed early diagnosis of the tumor in this region, which is important for the plan of the kind of the intervention. After that is imaging diagnostic procedure, a very important improvement in this region, because with CT scan we can see the invasion of the bony part and destruction, but in some vague cases, like in that, when you can notice that there is something in the endocranium, you will take MRI, and on this way you have a complete impression about the volumen, about the structures which is involved in the spreading of this cancer. Biopsy is also important, but in some cases it is really extremely hard because the tumor pushed the soft tissue, mucosa, and sometimes the biopsy is false negative. That means we don't reach the area of the tumor, we reach the mucosa, normal mucosa. And what is important is to have good cooperation with the dentist, with the orthodontist, to ask them for the help before you start to perform some surgical intervention, because after we get the problem, it is hard to resolve that problem. For the better understanding of the tumor of this region, for the better understanding of the invaded tissue and how to plan the intervention, there is many classification. Many classification has been proposed in the last centuries. First, as you know, is Ongrin, who classified this tumor on two parts, anterior inferior, which is more benign, and posterior tumors, which is really aggressive because it can spread over the orbit or endocranium. Then is Lederman classification on three stage, supra stage, middle stage, infra stage. He used the lines of dividing this middle face region according to Sebila, and we now use, of course, TNM classification 8th edition, which separate the maxillary sinus tumor and the nasal cavity tumors in the fourth stage, from T1 to T4, according to that which structures are invaded or infiltrate. Basic for the treatment of the tumor of this region is the surgery. In the greatest number of the cases, it is the open surgery, but I know that now we have a lot of the centers which used or performed the endoscopic surgery, and I think it becomes more popular everywhere, but still in our hospital, and we are able to resolve some small cancers, more cancer in small region with endoscopic surgery. Radiotherapy is adjuvant therapy and other kind of the well-known treatment. Sorry, it goes very quickly and fast. Other kind of the treatment is, what is that? I'm going back, sorry. Is adjuvant therapy, chemotherapy and biotherapy is for the advanced stage, for the recurrences and another situation. Endoscopy is now very well in usage for the small resection, as I said, for the combination with the open surgery to debulk the tumor and to help the surgeon to find the origin of the tumor and remove some bony parts, and of course to restore if there is communication, especially toward the endocranium, and to protect from the leakage. Also, there is many classification of the maxillectomy in the past. You know that the first was performed by the Dipitren in 1820. After that, it was done sporadically, but now there is a lot of this kind of the surgery, and I think that the most familiar is the classification by Brown, who classified these tumors on the four types. According to the vertical components, first is the limited maxillectomy, that means resection of the one wall of the maxilla. This kind of the resection in some patients not need to perform some reconstruction, some prosthetic device. Type 2 is subtotal maxillectomy, that means two walls is resected and there is a communication with two space. It should be reconstructed. Total maxillectomy with enucleation, not exenteration of the orbit, is a classical operation, and type 4 is the orbitomaxillectomy, which is really big operation. And there is, I don't know what happened. Maybe I breathe and remove the picture. No, flex, okay. And subtypes is according to wide of the resection of the hard palate. You know that reconstruction to 1919 based on the different prosthetic device, and we are very familiar with that and have a good experience with our orthodont, who with this device separate the oral cavity with the nasal cavity and reestablish the very important chewing function, or aesthetic results with the patient with orbitomaxillectomy. But after 1919, there is a lot of the reconstructive surgery in this region, flap surgery, with the general rule that first is important to reconstruct the bony part, then soft tissue, and it is possible to put some dentist prosthesis or dentist implant in this region and restore completely chewing function. Of course, these flaps have the disadvantage because if the flap have the petiolus less than 10 centimeters, it cannot reach the blood vessels in the neck, and it is very hard to connect them, and you need to put the vein graft. With this kind of intervention, the functional and aesthetic results become much better. about the metastatic process in the neck lymph nodes, we know that this region is really poor with the lymphatic network, and that in the human studies with 96% of the N+ neck, always the level which is involved in the metastatic process is level 1 and 2. That means upper jugular and submandibular lymph nodes. Other, such as retropharyngeal and parapharyngeal, in the advanced cancer in the group 3 and 4. We know that the most often histological type who make the metastasis is squamous cell carcinoma. Other types are rare. And according to the guidelines, in N0 it is not necessary to perform some elective neck dissection, but new recommendation is in the cancer more than 4 centimeters in size, in volume, it is recommended to make the elective irradiation. And of course, different kind of the neck dissection if the neck is plus positive. But what is the general view of this cancer is that there is a lot of the recurrences, up to 70% is overall recurrences. That's because it is very hard to make the radical resection of the cancer in this region, and you always have the positive margin. And because of that, local recurrences comes up to 70%, and only 20% of them is possible to operate. In the neck, you have up to 30% of the recurrences, but more than 50% is positive. Is possible to operate. And if you look at the literature, there is a great series of the patients. In this region, great series means 100 patients or closely to this number, and there is a great number of the local recurrences. For example, in the group of 116, it's 68%. When we look at the neck, the number of the recurrences or percentage is about 20 to 40%. And the survival rate is low in the squamous cell carcinoma, about 30%. But if you look at other types, for example, adenoid cystic carcinoma, it is about 60%. And finally, to present the results with our patient, it was the 56 patients which I summarized during the 10 years period. You can see that the most often sites of origin is maxilla, then nasal cavity, but in 30% it is very hard to say is it the tumor originated from the maxilla or the nasal cavity. Also, we did the TNM classification of this tumor. The most often was a squamous cell carcinoma, about 50%, 53. And a lot of the patient was in advanced stage of the disease, 62%, but only 4 had a neck positive of all of them. We performed in 47 surgery, open surgery 42, and in 5 endoscopic surgery. The most often it was the total maxillectomy, in 7 orbital maxillectomy, and the results of treatment are that overall survival of all operated patients, 5 years is 38%, but surprisingly in squamous cell carcinoma we had a good result, 62% of the patients. Other histological types was not so successful. And the conclusion is that the malignant tumor of the sinonasal region continued to be the diagnostic and therapeutic problems. Early diagnosis, endoscopic examination of the patients with the disorders of this region give a great chance of early detection of the malignancy. Better imaging diagnostics, either CT alone or in combination with MRI, improves the local assessment of the tumor expansion and thus a better treatment plan that affects survival of the patient. And the surgical treatment, endoscopic or open surgery, is still the basic approach in the treatment of malignancy in this region. And thank you for your attention.
Thank you very much for this interesting presentation. Do you want questions, Professor Perik, or finish? What do you want? questions? Okay. All papers are open for discussion. Anybody who would like to? I know, Mark, you wanted to question crystals, or is it already solved?
No.
No.
Thank you for your nice presentation. I have one question. Do you have any experience with sodium fluorescein to color the seas?
You mean intrathecal fluorescein or
fluid?
topical fluorescein? No, intrathecal, yes, both intrathecal and topical. We have also tried, I'm saying topical because there has been a suggestion recently to apply fluorescein in a small, you can use it in a small cotton bud, how do you call it, swab, and apply it internally, endonasally, on the area you suspect the leak, and this can color as well. So I have experience, I think most people have experience with intrathecal fluorescein. It has been around for now almost 20 years. It can be helpful in localizing the CSF leak. I think that it creates really nice videos when you see it coming and then you change the filter on the camera, it becomes green. It comes really nicely. Most of the videos I have seen, however, the way I saw the videos, the leak was obvious anyway. It didn't really help you to identify the leak. In cases where the leak was very, very small and you had to look to find it, I think in most of these cases, if one had a better look before the surgery and really carefully look at the CT and the MRIs, he would have been able to visualize it. And that's what I wanted to insist. It can be helpful. Personally, I think sometimes we had issues with delivery, with the time to onset of action. In other words, sometimes we try to do it the night before the surgery, so you have enough time for this to circulate. Sometimes we do it just 1 hour or at the induction of anesthesia. In my hands, at least, it hasn't been consistent in its presence. I haven't always seen it. So that, plus the fact that I really would feel very uncomfortable to operate in a patient if I haven't localized the leak preoperatively, means I don't really use it that much. But that's my experience.
Thanks.
Well, what's your experience?
Thank you.
Someone else from?
Okay, any other questions from the audience? Or is everybody... Yes, go ahead. I saw a hand, Eliana.
Thank you so much for wonderful presentations. One question for Professor Busaba. I wondered, are you tapering down when you're giving patients verapamil? I apologize if I missed it on the slides. Do you just stop the treatment or you taper it down? And did you have any adverse effects after stopping it, if not tapering it? Thanks.
Which treatment are you talking about?
Verapamil.
Verapamil. This one was, as of now, all of these are on the research protocol. So yes, we finish it. So we end it, we don't taper it down. So after the treatment, we take them off it. Well, again, we chose the dose. We chose the dose that is commonly used for cluster headache. This is a safe dose. It has very minimal side effect, and then we monitor them by EKG pre and post.
Thank you.
And how long do you keep them on? I mean, not in a trial, but in your normal.
As of now, no one is on it on a long term. As of now, it is only trial, and as of now, up to 12 weeks.
Okay. Any more questions? Everybody satisfied for this moment? Or in need of a drink? Well, both at the same time, maybe. Then I would like to close the session. Thank the organizers again, and see you all tomorrow morning at 9 o'clock. Or tonight for the dinner.